right, and make sure this works. Thank you so much for inviting me. Thank you for different sponsors. And here are my disclosure. I don't have any financial disclosure. And here we go. I would go directly to the subject. And we have a question this afternoon. And if you're interested in the slides, I will leave them with Paula, who was so helpful, and feel free to ask for them. So my name is Bernadette Grosjean. I'm a psychiatrist. I was trained in Belgium, where I worked for 20 years, and then I worked for 20 years in California, where I was a professor at Harbor UCLA until 2016. Around 8 years ago, I realized that a number of women referred to me because of my expertise in borderline personality disorder were in fact autistic. It was their different neurology and its impact on their mental health that explained many of the symptoms for which they had been sent to me. Eventually, as I learned more and more about autism, I recognized that myself, I was probably autistic. It was an eureka moment in some ways, but it took me by surprise as I still had in mind old stereotypes about autism. How could I be autistic and be able to successfully work as a psychiatrist for 35 years? And then how come that time and time again I was told by friends and colleagues that I was one of the most empathic persons they ever met? Aren't these people, the autistics, lacking empathy and theory of mind? It is true that growing up, I identified fondly with Dr. Spock, and I was often pondering if I too was coming from Vulcan. In 2021, I went through the full battery of neuropsychological tests that confirmed that I was autistic with a pretty spiky profile. By sharing that with you today, that I am an autistic psychiatrist, I am taking a risk, the one that you may dismiss what I say on the account of me being different. This strange logic is called epistemic injustice and happens when people, often from a minority, are questioned about their ability to have and share knowledge about themselves, which seems a little bit absurd, but it's the reality. Hopefully, for most of you, the added feature of me being autistic may mostly increase your interest. But because the word autism is associated with so many stereotypes, you may be tempted, consciously or less consciously, to disqualify some of my observations. If this happens, please try to be aware of it, write it down, and bring it later to the discussion, but please keep listening. I am talking today essentially about autistic adults without major intellectual disability. Speaking about that population, the less visible but largest autistic phenotype, probably 60 to 80%, does not mean that I want in any way minimize the struggles experienced by autistic children, adults, and their families when autism is associated with multiple and incapacitating intellectual and physical disabilities. They need, of course, and deserve adequate support from their community, their government, and their doctors. But recognizing the struggle of one group should not prevent us to take care of another one. Adult psychiatry is what I've done for 35 years and what I know a little bit. And it is obvious for me that many autistic adults that have not been identified as such have had their suffering ignored or misdiagnosed for decades, and as a result received inadequate or harmful treatments. By becoming better at identifying them behind behaviors, we can make a huge difference in their life and ours. Before plunging into behaviors, let's clarify the concept of autism as I see it today. Autism is not an illness that can be cured. It's a neurodevelopmental difference. Autistic children grow up to be adults, and autistic adults, they don't disappear somewhere after 18. Autism is not rare. It touches 1 out of 36 people in the US, and I probably that underestimated. Very important, autistic people have empathy, have theory of mind. They are just different from non-autistic people. And these stereotypes of lack of empathy, lack of theory of mind have been absolutely devastating for us. And autistic people, as I said earlier, don't have necessary intellectual disability. We have a recent study where showing that for English students before 15 and 19, and we're systematically looking for autism, and only 10% of them had an associated intellectual disability. So here's for me a definition that works for me in my work and personally. Autism is a different way of perceiving, learning, thinking, processing, relating, and reacting to both our internal and external world. Keep that in mind. It will also be very important what I'm going to show you later in terms of how autistic people perceive and process information. A few more additional updates. It's no longer the problem of white little boys. It's of course present in both sexes, probably 1 woman for 3 men for no, maybe a little more, in every age, religion, class, profession, every level of ability and disability. There is a surrepresentation of autistic people in the LGBTQ population. The range of symptoms, of course, depend on the individual and its circumstances. And autistic people without measured disability generally work, may have a family, read, write, perform all kinds of activities. And here the study I mentioned before. Now, about labels and how we speak about people and what they may live with. I love this word. It was created in 2017 by Kerry Opai, who was a Maori man, because they needed to create a word for autism. And the translation of Takiwatanga is in their own time and space. And I think it's a beautiful definition, because the development will be in their own time or own time. And space, of course, is something extremely important in terms of what we need and what we don't always have. You've heard probably a debate about low functioning and high functioning autistic. And the problem with the low functioning or severe term is that it may lead to a general dismissing of a person's abilities. I think it can also cut hope and make people give up on potential strengths. And if we do that, we may make big mistakes. You all know Temple Grandin, I suppose, and you know that when she was 2.5 and not speaking, the doctors told her parents, she's brain damaged, send her in an institution and forget about her. That was 1947. Thank goodness the parents didn't do that, and we know the work that Temple Grandin has done since then, and so many other people. Imagine we had given up on her. Imagine how many people have been sent in institution and couldn't become who they could have become. So I think it's very important to keep that notion that things are in a different time. It's a neurodevelopmental difference. Not everybody will become Temple Grandin, but certainly we have to keep hope and work and see what are the strengths of a person. Here's Jason Hardy. You may have seen him in the social media a few months ago. At 37, he became the youngest Black professor at Cambridge University. He couldn't speak until 11. He couldn't write until 18. So the high functioning label is a problem too, because it implies that the person has no problem adapting to the neurotypical world, and that pretending to be normal doesn't cost in terms of emotional and physical energy. And of course, it's not true. We will come back to it, but it can be extremely costly and create a favorable place for psychiatric problem. So for these reasons, the community prefers using the term high support needs or low support needs. and all that in place of high low functioning. So let's come to the behaviors. And what do we speak about when we speak about a behavior, right? It can be a range of reaction, a range of mannerism, a form of response, the forms of response to internal and external stimuli, a form of communication, of course, when sometimes the words are no longer there, and pathologizing different and inconvenient behavior has been there forever. And this is an example, I don't know if you're aware or familiar with it, but in the 19th century, psychiatrists create a new illness, psychiatric mental illness called drapetomania. And that was the illness supposedly from slaves who were trying to escape. And who can want to do that in their normal mind? So we see how culture, politics, money are influencing medicine in general. We also want sometimes pathologizing simple different. I don't see you very well, but anybody is left-handed in this room? A few, right? Well, do you know that left-handers are one of the most consistently attacked minority groups? Until very recently, being left-handed was considered as a sign of perversion or psychopathy by famous psychiatrists and psychoanalysts alike. I think what's interesting too is to see on this graph the proportion of the population who is left-handed. So when you are very discriminated, right, until the 20s, you don't have many left-handed people, at least officially. One, it's no longer something you will be discriminated for. As you can see, we have an epidemic of left-handed people. Of course, we don't have an epidemic. People just are more free to be who they are. Now, when we speak about behavior, concerning behavior or behavioral concern are of course not unique to patients. They can also be witnessed in the people who supposedly care for them. You have heard of Asperger, who sent the majority of his young patients, so-called feeble-minded, to a place where they were euthanized through starvation and infection. Bruno Bettelheim, who lied about his credential, was not a psychoanalyst nor a psychologist, and made up that horrible theory where he compared the mother of autistic children to Nazi guard and blamed the mother for being the cause of their struggle, their child's struggle, which of course is not true. Or Lovaas, who did not see autistic children really as real people. These are not my words, it's his words, and he said that many times. He didn't see them as real people in the psychological sense and encouraged the autistic conversion therapy, it's a term coined by Amy Sequencia. These men and a few others contributed to the belief that it was not a real person inside the autistic body. Children were empty fortress, in quote, devoid of feelings or mind, whose disturbing behavior had to be controlled or is extinguished at all cost. The DSM didn't help very much. As we see, the DSM, which has been criticized by many people, including the one who wrote them, and the medical model, didn't bring much more humanity because the diagnostic criteria basically are describing people only in terms of deficit. And as you can see on this slide, right, deficit, lack, problem, missing. This is like an only one way to look at autism. And it's really regrettable, right? Because we want to look at the entire person, as I said earlier, to have hope, to see what we can work with, what we can give help to. And as we see here, being autistic means also a lot of difference, and difference that can be sometimes extremely useful. But, of course, being different in a society that is not willing or equipped to accommodate this difference can have huge physical and emotional price. For instance, a shorter life expectancy by 20 years. And I speak about autistic people without intellectual disability. When you have intellectual disability, your life is shortened by 35 years. The first cause of death is cardiovascular disease, which makes sense when you have poor access to care, you have difficulties to ask for help, and you're constantly in a state of stress. But it's also absolutely tragic. It's suicide is the second cause of death. In general, in the US, for instance, is the 11th cause of death. So as I said, it's much one of the reasons it's very hard to access care, and we will see later one of the reasons is the difference in perception. There's a high level of unemployment and a high level of burnout. Now, which behavior are we talking about? Aggression towards self or other, unusual behavior. We can look at behavior that can be concerning for people around us. Unusual social interaction, unusual sensitivities, not seeking help, not going to get a health check. So, as I say, if you know how to listen, maybe this behavior can tell us who we are. But how do we listen? What do we listen to? We cannot make sense of behavior, in my opinion, without knowing what is happening inside the person. So to help you to know what to look for in terms of what can explain or trigger a certain behavior, we need to know more about how the autistic minds and bodies are experiencing their environment. And probably the most important part of that, the most important things you want to be attentive to, and each time you're working or you're in company with an autistic person, really pay attention to is what's happening in terms of perception. Our human brain processes 11 million sensory impressions per second. Of course, we're not aware of that. We would be unable to do anything. Humans are conscious about 40 or 50 of these sensory impressions. That's what we call perceptual capacity. One of the very big differences, if the only things you remember from this talk, is that autistic people have a higher level of perceptual capacity. So they may take, I have no idea how many, but in place of 40 or 50 of this impression, maybe 80, 90, 100. And probably the more you get this perception, the more time you need to process them, and it comes to a point where it may be hard to process at all. Atypical sensory experience are reported to almost 100%, let's say 97% of autistic people. Something that's very important too is that, and what I'm telling you, I have papers to prove that there are MRI studies and all that. This is very, very important. When there is a noise, like whatever white noise is in the back of this room, the majority of people get used to it, stop to hear it. The lights right now, that's in my face, majority people will maybe get used to it and not be irritated by it or distracted by it. It doesn't work in the same way for someone who is autistic. We don't have this habituation. So the same intensity of noise will persist for me, for instance, for the rest of the session. Now that is very important because you may be in a situation where there's a little bit of noise, a little bit of distraction, and you're fine with it after a little time. If you are with an autistic person or child with you around, they keep being annoyed by it for hours. And if you can tell them, stop thinking about it, right? Forget about it. Well, that's the problem. The brain doesn't work that way, and we cannot really get habituated to. It's also very much implications for treatment. Remember autism treatment where we try extinction and we expose you to some stimuli and hoping that your brain will get used to it. It doesn't work for autistic people, at least for a majority of them, and it becomes kind of a torture. Very important is that these sensitivities stay the entire life. So people may have learned to mask their autism, they have learned to make eye contact or looks like they're doing it. But if you ask them questions, clearly these sensitivities may persist for the entire life. So the result, of course, is that you can be overloaded. It's extremely exhausting when you constantly have all this perception. The way these perceptions are processed and interpreted is also different in the autistic person, by the way, including the perception of time. And I always ponder if it's one of the reasons Einstein made that theory of relativity. The processing can be slower or faster or present with greater intensity. So another way to process when you have all these perceptions at the same time is to be biased toward local details rather than the global configuration. So that this person who say it's like if I was tuned up on 40 channel on the 40 television that I would look at the same time. Maybe someone who is not autistic will be the equivalent of 3 or 4 television screens. So you can have a global idea of what's going on if you have 3 or 4. If you have 40, you're going to have to focus on some more than others. Sensory issues are hence one of the major reasons why healthcare environments can be experienced as inaccessible or unbearable. You can also imagine when you're brought in a hospital in an emergency room, the accumulation of noise and light and stress, how difficult that can be. So let's start and go more or less quickly through these different perceptions. First, vision. And one of the famous difficulties for autistic people is well known, is eye contact, right? Eye contact is, we tend to avoid it. Why is that? And it's also the focus of a lot of therapy. Try to teach their children to make eye contact. As you see, what people say here, it's extremely hard. It prevents me to think. It's extremely stressful. Well, science is helping us, since the words of the autistic people are not always enough, and explain that when you are forced to have an eye contact or look in the eye for a prolonged period of time, you have a hyperactivity of your amygdala. The amygdala is kind of your primitive brain, reptilian brain, is the center of a lot of things in terms of emotion, but the center of fear. So what the imaging is telling us is that when you're forced to make eye contact, it's so powerful that your amygdala, your center of fear, is activated more than someone who is not autistic. So we understand why eye contact may be quelque chose that's very difficult. And of course, in terms of vision, you have hypersensitivity to different type of light. You can also have a fascination for a certain type of light. And something that's a characteristic for probably 30% of autistic people is they don't recognize face. They may recognize details of a face, but they generally don't recognize people. It's something very, very common, which can, of course, in social context, be a little difficult. Hearing is another sense that can be fantastic, right? You have a great sense of hearing, a great sense of musical hearing. You hear things people don't. That can be fantastic, or that can be absolutely exhausting. So that hypersensitivity to sound, or that a question you want to ask a patient, for instance, if you meet with them and try to identify what's going on, it's a source of distress for a majority of autistic people. In particularly 3 types of noise: the sudden, unexpected, like a dog barking, the continuous noise, like vacuum or leaf blowers, and the complex of multiple sounds. Imagine you are at an airport. Again, you don't have this habituation, so you hear it constantly, which it can be exhausting. Something important too is a great sensitivity to the tone of voice. So you can speak to someone and think you're just nice and neutral, but if it's just a hint of stress or anxiety or irritation, the autistic person is going to, in general, taking that at 300%. So smell and taste, I'll go a little faster here because it's the same, in fact, right? So you have hypersensitivity to certain smell, to certain taste. It can influence how you will eat, and we know that a lot of eating disorders are present when we're autistic. It can also prevent you to do some work, right? Try to work in a hair salon, right? With the noise, the smell, or the activity. So there are some, when you try to help someone to find a job, you really want to take that into account. Another very important part is the touch, and we know that it may be very difficult for autistic people to be touched. That light touch can be experienced as something that's really hurtful. We know that sometimes heavy blankets are helpful. So there's something in the touch in that sense that's also different. So you're not surprised by no. And that can influence, of course, our behavior. So difference also in the perception of temperature. And something I discovered preparing for this talk is one of the explanations behind this difference in touch and how we perceive and we experience it differently is the difference between two types of fibers. You have a type A fibers, discriminative touch. That's more or less everywhere, and that goes directly to the brain's sensory center and will give you information about pressure. And then you have the type C fibers, who register in the emotional part of the brain, right? It's touch, but it's going directly to the emotional part of the brain. And we know that for autistic people, there is some problem with that, the way these C fibers are functioning. Touch, we are now in pain, in the sense of pain. Again, you saw what Lovas was saying. For a long time, we are so supposed that autistic people wouldn't feel pain, which I suppose justify for some the physical abuse really in treatment. And well, all that is not correct. Autistic people feel pain. Actually, there's an atypical perception of pain, and you have a combination of an increase, actually, of feeling of pain, and the signal that help to suppress that feeling of pain doesn't function very well. Something important, too, is the mix of physical and emotional pain can like additional and reinforce one another. And you may have an increased response, including in your amygdala, when you anticipate the arrival of pain, the coming of pain. We have another sense, interoception, that's very important. It's telling us what's going on inside our body, including pain. Well, there too, you have big differences for autistic people in both directions, because each time you can have hyper or hyposensitivity. In general, for an autistic person, it's very difficult to identify how painful something is. That's why so many arrive in emergency only very late. And it's also a problem of alexithymia, which is difficult to put words on what's going on in terms of pain. So after what I just told you, you can imagine that you can be, when you're autistic, be more easily overloaded by all this sensation. And that can be absolutely exhausting and can trigger all kind of behavior. Believe me, we're going to come to the behavior, but I want you to understand that and to understand what to do in confronted to this behavior. So when you're coming to that overload, you may have an increase of stimming or withdrawal from the situation. You may be talking faster or stop talking at all, be more anxious, and we'll see it can evolve in a shutdown or a meltdown. I suppose you're aware of what stimming means. I think it's very important to remember how useful stimming can be. It can help you to calm yourself, to protect yourself about overstimulation, help you to concentrate. Of course, we want to be sure the person doesn't hurt him or herself too much, but it's certainly something, and I think everybody is aware of that, that we need to try to extinguish at any price, as is being tried, right? Don't stim, don't move, don't do that. But it's a very good way to let go out some of the anxiety and some of the stress. Motricity is also different. There are difficulties with fine motor skill, and this impression of clumsiness, who make that the autistic child is quickly identified by the bullies in school or elsewhere. Interestingly, this difficulty, for instance, in throwing a ball or receiving a ball, we don't have it with certain sport. So when you're autistic, you're probably better at going for trying swimming or doing trampoline or playing golf or horseback riding. These are certainly activities where you don't have these difficulties. In terms of motricity, I will speak about that later, but the very important things to know and to identify is that catatonia, the fact that you suddenly stop moving, stop talking, right? It's a rigid position, which is associated in the past with schizophrenia only. It's only 10% in schizophrenia. 15 to 30% of autistic people may have catatonia. We'll see later, it's very important to identify as such and not to treat it with antipsychotic, for instance. So all this is linked, of course, but you perceive the world in a certain way. You interpret your perception in a certain way, and then it's going in your mind, and you react to it in a certain way. You analyze it in a certain way. And that's what we call cognitive process. And a reminder that cognitive processes happen in your brain, but happen in your gut too. I'm just coming back from the American Psychiatric Association meeting in San Francisco, and we had multiple lectures about how what you eat, what you put in your guts, the microbiome in your guts will influence so much that's happening in terms of mental health. That's another talk in itself, but I want you to remember that. It's extremely important. So I spoke about a spiky profile in my introduction. Anybody knows what it is? Familiar with it? So when we do neuropsychological testing, one of the way we realize that someone is autistic is because when you test all different range of cognition, memory, executive function, and all these different tasks the brain does, autistic people in general don't have they have some fields of knowledge where they are extremely good, like at the 95, 90 percentile, and then some other where they are at the 30 percentile. So they're really not doing good, not doing well at all. So they can perceive something at the 99 percentile and process it at a speed that is on the 30th percentile, so very slow. So you have a spiky profile, right? It's not kind of equivalent among different tasks that you're testing. That's also why we cannot really speak about autism as a spectrum, but more, as you see here, as a mixing board, with some perception very high, some processing, or some memory that are not as functional. And that's what we call a spiky profile. So if you look here on the slide, right down, what you see on this graph is one relatively even line, which is the one of someone who is not autistic. And the spiky profile of the autistic person show that, for instance, in terms of verbal, the performance are really great, verbal and visual skills, but in terms of working memory and processing speed, is very low, right? This is neurocognitive testing are extremely expensive, they are long wait line, and it's not easy to get, but it's very useful to help also a person to see what they're strong in and what they're not. So all this cognition and perception give an autistic brain certain particularities, right? And some autistic people speak about their mind as a form of operating system. And as you can see, you can have some qualities I showed earlier, hyperfocus, but hyperfocus is something great. You're going to work for 10 hours without stopping, but it's not very good because it's hard to shift tasks. You forget to go to the bathroom or to eat or to drink, and that's not necessarily good for your health. You have very good pattern recognition. You have different approach to complex problem, perfectionism, thinking of one thing exclusively, again, it is pro and cons. Looking at the details before the concept, that's what I'm doing with you today, and a lot of difficulties with executive functioning. So when I say that's what I'm doing today with you, is that we're going from in place of going from behavior, what's the behavior, why do we explaining it, how do we explain it, what I'm doing is to explain you the mechanism, basically, of what's going on inside our brain and our body, and with that, you will be better understand what the behavior means and what to do to help the person. It's also helping because you don't go from generalization and try to make what's happening fitting that generalization. You go, in general, without preconceived idea about what's going on, and you can make discovering that way because you're not influenced by what the majority of people are thinking. I mentioned that memory is also different. So the way an autistic person remembers their life is not the same as someone who is not autistic. They have, in general, a very good memory for fact, But the difficulty comes with episodic memories. So memories when you remember something, you're on vacation somewhere with someone, you meet this other person, you were feeling that way. In general, for an autistic person, these memories don't come spontaneously, which makes it very difficult sometimes to write an autobiography or speak about your life. However, if you give a cue, if you get a hint in what we asked, you remember this vacation in 1999, then the memories can come up and open up. Again, it's very important when you do an anamnesis, when you ask questions and you ask questions about the life of someone, don't leave open-ended question. We may not be able to know what you want me to talk about, but if you give hints, then the memory can open up. Language is different too. And it's been, remember the little professor, which was Asperger, actually definition. So the autistic narrative is described, I hate the word pedantic because it's a negative connotation. I think the kids use words that are complicated and he knows what he's saying. It's just a smart kids or sophisticated, but that's the way it's said. Idiosyncratic, right, a lot of neologism. Misuse of pronoun can be a sign that when you work in a language that's not yours, it's more difficult to know if it's linked to autism or to your knowledge of the language. Loose association, illogical, fusion of ID. Is reminding you of the style of someone? James Joyce here. If you read James Joyce, you will see which was autistic. A lot of the characteristics of that are in the style of James Joyce. Doesn't make you psychotic, it makes you different. But of course, in terms of social interaction, things can be more complicated. So communication and social interaction, social language is a second language, right? It's important to only what we say, but how we say things, our intonation, the body language, how we deal with interpersonal relationship, how we deal in a certain social context, if there are noise, if there are multiple people, not only one person, if the situation is predictable or not, or that will influence the ability to communicate. The DSM, of course, stipulates autism as a deficit in social communication. That's one of the big criteria. And in general, when an autistic and a non-autistic person interact, it was considered until recently that only the autistic person was responsible for the deficit in understanding. But is it only the problem of the autistic person? To understand a behavior, it's important to understand the person. And when there is a language barrier, misunderstanding can, of course, have a lot of problematic consequences. So this is a slide I made expressively for you. I don't know, who speaks Maltese in the room? Oh, perfect. So you see what I'm writing here. Here's the context for my example. For 16 years, I worked in a big public hospital in Los Angeles, close to the airport. And regularly, I would be asked to come to evaluate French-speaking patients in the psychiatric emergency room to have a sense, I speak French, to have a sense if their agitated behavior was due of them being psychotic, for instance, or simply being French. So let's imagine that one day, Joseph, who speaks exclusively Maltese, come to the ER in Los Angeles because he had abdominal pain. It's very hard for him to communicate what's going on, and he's getting increasingly scared and frustrated and agitated. He cannot really communicate. So the ER doc who heard bonjour and think it was bonjour in French called me and asked me to see the patient. It's an imaginary case, of course. So I see the patient, I speak a few languages, so I try to make sense of what he said, right? I see enfermiera, muscle, bonjour. I'm thinking, oh, it's maybe Spanish, maybe, you know, what kind of language is this? But a lot of words don't make sense to me, and I didn't know anything about the Maltese language at the time and the richness of it. And so some words don't make sense, and I'm starting pondering, maybe he's delirious, maybe he's psychotic. Of course, Joseph is more and more frustrated and scared, and he's in pain. So I want to examine him, and I'm going towards him, and in a movement of exasperation or frustration, he pushes me. Yet there was no ill intention. I think he was just scared. But nobody knows what's happening in the head of Joseph. And a nurse sees him doing that and calls immediately security. And then it becomes a big ordeal for Joseph. And maybe because we're going to put him in a confinement room or in restraint, nobody will pay attention to his abdominal pain, and that can have terrible consequences. So what happened here, that was me, is a misattunement of mind and of languages, right? You want to express something, I think I understand. If I didn't understand a word, then I would say, oh, we're different. But I think I understand, and based on that, I make the assumption that he's psychotic, let's say. What I describe here is the Maltese-American version of what Damian Milton described as the double empathy problem. Like an English-speaking doctor interacting with a Maltese-speaking patient, research has shown that non-autistic people struggle to understand the emotion and thinking process of autistic people just as much as the other way around. So the difficulty here may lie in how people who have different ways of experiencing the world interact. That conception of double empathy has been crucial. It was brought by Milton in 2012 to really bring back humanity to autistic people and the myth that they had no empathy, that they don't have a mind that we can understand. It may be very hard for autistic people sometimes to read emotions in others, to interpret, to know the social language of how to react to it. But that doesn't mean they don't feel the pain once they realize the other person is in pain. Actually, studies show that autistic people generally feel more empathy, more pain or more stress when they're confronted to the stress of others, and not only other human beings, but animal and sometimes objects. So you have in mind the difference in sensoriality, the difference in perception, the difficulties in interaction and communication, and you can understand how suddenly certain things that may not be stressful for someone can be incredibly stressful for an autistic person. What made it more difficult also is that in general, when someone gets upset, it would go from 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. For an autistic person, often, due to all this hypersensitivity, you do 1, 2, 3, 10, right? So that can bring those behaviors of concern, this explosion that we don't know where it's coming from and what we can do for. So emotion dysregulation is when our emotions are stronger than our capacity to regulate them. It interferes, of course, for goal. And sometimes people may not show that they dysregulate. We call for regulation. So they seem, as you see with the mask, they seem okay. And then suddenly you have the explosion and you have no idea why. So to understand how people can react that way, very violently sometimes, think again of our more archaic brain, the amygdala, the center of fear, and which the center where we are suddenly in fight or flight or freeze position. This is extremely important. Again, you may be in your hospital working, doing your job normally and all that, but the person who is brought to you may be ready to be in a state of terror, and that will, of course, influence our behavior. I'm going to go quickly on this, sorry. So one of the most important phase and common phase of autism is the meltdown. That's the one some people put on TikTok, unfortunately. This is a situation where you are in a fight, flight, or freeze response. You are in a fight response, right? And you can explode, be violent, sobbing, wailing, kicking, including people who are normally not doing that, or give lectures, right, or who are professional, who are your colleague at work. You don't imagine they suddenly have that literally meltdown. Remember that meltdown, it's not a manipulation. It's not trying to make the life of people difficult. It's really suddenly this explosion that's impossible to stop. People cannot stop it, which is different from a tantrum, by the way. So triggers, now you have a sense of what can trigger this overstimulation, but also a change of routine, something that seems absolutely unfair or illogical. Remember, brain of autistic people is very logic. Justice is very important. Having a routine is very important. Losing a routine may be incredibly triggering. And so all that can create it is a meltdown. So what you do when you see the GPS, I really like that comparison. Remember the GPS, if you drive and you do something that you turn left in place of right, GPS doesn't start yelling at you and say you're really stupid and why are you doing that? They just calmly bring you back to the road, right? So think GPS, I think it's a very good way. Stay calm and reassuring. Don't try to identify the trigger, right? Turn off the light. Engage in a minimum of conversation. Do not shame people. It's already embarrassing enough. And try to protect a sanctuary. Avoid eye contact. Avoid touching the person if you really have to do it. Make sure it's okay, right? And of course, it is that context when you are in a hospital that you may consider giving medication, sometimes to help the person. But again, do that, really explain what you're doing, why you're doing, right? Jumping on someone and giving a shot will certainly not help anything. Self-injury is very frequent in autism. That's one reason why so many autistic women are misdiagnosed with borderline personality disorder. It's a way to try sometimes to calm yourself, form of stimulation. A lot alexithymia, so not being able to put words on what we're experiencing is frequent and increase the risk of self-harm. I've told you earlier that the center of pain, emotional and physical pain, are working with one another. So you can imagine that if you create a physical pain and bring some endorphin, it's going to help with the emotional pain. So all that is very important to consider. The other side, now you have the meltdown, that big agitation. The other side is the shutdown. So suddenly, as patient would say, let's go on a sleep mode on your computer, right? Again, you had all this stimulation, all this anxiety, all this stress, and you just shut down. You start talking. Actually, some people who talk like, let's say I have a terrible stress. It didn't happen to me so far, and I'm brought to the hospital and I'm so stressed, I cannot talk. Now, let's say I cannot talk and my gait is a little weird and I'm alone. There's nobody to tell the doctor, you know, she was doing this and now we're worried. In general, the doctor going to interpret that, oh, she's drunk. Let's put her in a room and forget about it until she's no longer drunk. That happened quite often. So that's why when I speak in the past about high functioning, right, here's someone who functioned very well, were not necessary. And some of the problem linked to the fact that you're autistic can really put your life in danger at time. So the shutdown is you have no energy, you can dissociate from talk, you really need to be alone, your voice can change tone, the person seems like a different person, and you have catatonia, as I spoke earlier. So you really, and that catatonia state can be for minutes, for hours, or for days. And of course, it's for days, it really needs to be addressed because you are in danger physiologically. So how to handle shutdown? Identify what's going on, right? If we keep yelling around the person, or if the light is very bright, if we are yelling at them, well, of course, that's going to help. That's not going to help. It can help to push you in a meltdown, possibly. Don't try to activate the person. That's very important. So identify the triggers. Some triggers, you know, we are 12 in the ER, the small ER room. Let's have as many people out as possible, trying to bring calm. Ask what the person wants. Again, try not to talk a lot. Ask before touching. And make sure the person can sleep in a safe and calm place. Don't push, and that's where sometimes some therapy where we try behavior activation, right? Like push the person to do something so they're going to get better. It's really totally counterproductive here. It's not that we don't want to get out of it, it's that it's impossible. And again, case of full catatonia in the long term, we speak about that later, you consider medication. Fight, flight, freeze. The flight is now the wandering. So, and again, it's particularly tragic when we are stuck in a hospital, right? We cannot run away in the forest to feel better, right? So this is something that really try to help us to get out of that situation, maybe find some solitude, find less stimulation sensorially, but it's very difficult to do it. By the way, we know that walking and walking in the forest is decreasing the amygdala activation. Now, you all know that it's really good for us. So take a deep breath, right? Now you have the tools. When you see someone, don't just think in terms of behavior. That's important. But the most important is try to see who is in front of you, what can happen, what they may trigger, what's going on. Of course, ideally, if you have people who can explain that, people around the patient, it's very useful. And then, how can we help, right? So something very important to know if you are able to ask questions to the patient or to the family is see if they have medical co-occurrence. Because we know that when you're autistic, you have a higher possibility of having certain problems, such epilepsy, such GI problems, autoimmune disease, extremely frequent, Ehlers-Danlos syndrome, extremely frequent, fibromyalgia, you know, all these weird immune problems that we don't always understand. Very, very frequent. So if someone, the family say, oh yes, you know, she has Ehlers-Danlos, just ring a bell. Think, oh, maybe it's someone who is autistic. That means I'm going to ask questions in a certain way. I mean, we should be calm and kind to all our patients, of course, but you may be more attentive to the sensorial part of what's going on. And as I mentioned earlier, if you're constantly in a fight, flight, or freeze position, if you're constantly hypervigilant, hypersensitive, you have high blood pressure, your heart rate is high, and you have a lot of cardiovascular disease and problems. In terms of psychiatry, and I ended by this because this is something you should know, right? You want to identify the problems that are there and address them almost like you would do with anybody else. Very frequent sleep problem, anxiety, ADHD, we're going to look at them in details, but basically, you know, being autistic is just it's a difference. So you have all the problem you can have to anybody who is not autistic. A lot of insomnia, a lot of sleep problems, less REM sleep. So you have 15% of REM sleep in 12 or 25, may explain also some of the anxiety. Sensitive to the environment, a lot of anxiety. Things in terms of phobia, if someone avoids something because it's a dog or because it's a dog that's barking and that's unpredictable. So that's important, again, when you look at the symptoms to differentiate where it's coming from. ADHD, very, very frequent. 35 to 65% of autistic people have also ADHD. Okay. Substance abuse was not looked at for a long time, but we realized, and it's not surprising, that it can, of course, help you to manage some difficult social situation. PTSD extremely frequent when you're naive, when you don't understand social rule in society, when you have all kind of losses, not understanding why, it's traumatic. And again, I will send you, I'm sorry, I have a lot I want to say, but you have a lot of mood disorders, 60% increase when you have camouflage, when you're burned out. I just want to come to the conclusion. And again, you will see the details here, how to differentiate this. Borderline personality disorder, I give you a lot of detail how to differentiate. So what do you do? Informed therapeutic approach, be calm, listen and believe what the person says, even if their face doesn't show what same thing as what they say. When confronted with unusual behavior, don't consider them personally, don't think it's something to make your life difficult or patients are resistant. Give people time, encourage regulation. In terms of medications, very important, consider the occurring different disorders. Autistic people are very sensitive to medications and to their side effects. So just be attentive to that. Start low in general. They have a very different type of reactivity to medication. So if they tell you they have side effect, even if it's a super low dose, again, believe them. Okay. So too many autistic people die too early, suffer too much from psychiatric and medical ailments without being able to be identified in time and to be given the help and tools to understand themselves better for the healthcare provider and for the healthcare provider to offer a more efficient and less traumatizing support. You can make a difference by giving them and us a safe, including regarding sensoriality, space where they can find calm and be grounded. by helping patients, their family, and you co-worker to have a better understanding of what's happening inside the autistic person and behind some scary behaviors, you can help everybody. Because now you know better what is different in terms of perception, cognition, and emotion regulation. You may be more aware of red flags when the voice of an autistic patient changes or if he suddenly stops talking. Of course, many of the involuntary triggering behavior brought by us mental health professionals when we work with autistic people were done without ill intent. When someone, oh, so sorry. From parents forcing a child to make eye contact because it's the polite thing to do, to a physician not taking seriously a vague complaint of abdominal pain by someone who doesn't seem to care and is a little weird, to the therapist to push behavioral activation, or the psychiatrist to incorrectly give antipsychotic medication, people had initially a good intention. They did not know, or maybe they didn't listen well enough and didn't give the person the benefit of the doubt. Again, that's why it's so important for you to have this other information, share with your colleague. Identifying autism is a relief for everybody when we are able to do it, including for the autistic person, which helps her self-acceptance and know better what to do to protect themselves from all these behavior problems. With time, exchange, tolerance, trust, respect, we can change our response to the alarming or discrete behavior triggered by pain, exhaustion, fear, and stress. And hopefully we can change these horrible numbers regarding a shorter life expectancy and suicide and never-ending internment. I hope my talk will inspire you to do so from now on, and I'd be happy to share all the information that was in the slide with you. Thank you so much.
Thank you. Thank you, Dr. Bernadette. I mean, it was extremely interesting what I was just speaking to a colleague. It's amazing, like, when you start seeing and learning different factors and different aspects, you start to look at yourself as well. I mean, I'm a parent, like I mentioned. I spend most of my time looking at my son, what's the best for him, and we don't stop and look at ourselves. And Dr. Bernadette has actually made me stop and look at myself and say, you know what? There are certain things that it's a way of dealing with certain emotions, and it's normal, and everyone has their own way. And it was extremely interesting, especially for me.